Today's podcast conversation is with Dr. Joel Kahn, a Detroit, Michigan practicing cardiologist and clinical professor of medicine at Wayne State University School of Medicine. Dr. Kahn founded the Kahn Center for Cardiac Longevity in Bingham Farms, Michigan. He's authored several books, including the most recent, The Plant-Based Solution, to lowering lipoprotein A, the heart's silent killer. Our conversation today with Joel was on what are the risk factors for cardiovascular disease? What are the tools that we have in medicine that we can utilize to best determine the health of the arteries that surround our hearts, right? It still continues to be the number one killer in the world. So we should do everything possible to look at our heart health and lower the risk. Then we dove into different nutraceuticals and diet for cardiovascular disease. Of course, we talked a lot about a plant-based diet, which is the diet that he promotes, reasonably so. So my conversation on cardiovascular health with Dr. Joel Kahn. Let's go. Welcome to the Dr. Geo podcast. I am your host, Dr. Geo, where it is my goal, my intention, my focus to help you with your prostate health and how to live better with age. Joel, everybody knows about you from the intro. We won't go into your intro. You obviously, by the way, such a pleasure to have you on. To me, it's like, I can't believe Joel said right away, yeah, I'll be on Geo's podcast. And that was easy and quick. So I really appreciate you being on today.
Thanks, Doc. Appreciate you.
Joel, so you are, tell me about your background a little bit. You are a cardiologist, you were trained cardiologist and then went into integrative medicine, or was it integrative medicine first and then cardiology? How did you blend the two? What came first?
Yeah, the short, quick bullet points. They're not all that amazing, but I was born with a heart murmur.
Oh.
I started seeing a pediatric cardiologist. I never needed a procedure like a surgical procedure, but I got interested in cardiology as a kid. And by age 10, you would have asked me, I would have said, I have no doctors in the family. That's what I want to do, though. Although I chose the adult route, not the childhood route, and got into med school pretty quick at age 18. And
you got into med school at the age?
They had a program, high school, right to med school, University of Michigan, to pump out more family doctors. You can tell I became a family doctor.
Oh, man. Oh, you never went to Ohio State?
No, I was 6 years in Ann Arbor, kind of an accelerated program.
I'm poking there a little bit because you're a Michigan guy. I'm trying to poke a little. Right. Clearly, you don't have that animosity towards Ohio State, those Buckeyes.
Yeah, I'm a very lukewarm sports fan, though. I'd always pick Michigan over the Buckeyes. Okay. Right from the get-go, was headed towards cardiology and became an interventional cardiologist. So I had a very standard practice.
What's an interventional cardiologist for our audience?
You got a heart attack, I got a balloon, I got a stent, I got a pump, I got nowadays all kinds of new devices. So you wouldn't have distinguished me much from any other cardiologist, except maybe I had a copy of a DVD of Forks Over Knives in my pocket to share with the patient. Because the only other part of my own bio was I grew up in a home where we kept kosher. I didn't eat pork. I didn't eat cheeseburgers. And when I went up to Ann Arbor, I adopted a plant diet. I didn't know what to call it. I just called it keeping kosher. But
was it for health reasons or for just practice?
Yeah, it started just to continue my tradition of observing an interesting code of Jewish law, which is food you eat, food you don't eat. And pretty quickly ran into people like John Robbins and soon after Dean Ornish, and a little later Dr. Esselstyn, the Cleveland Clinic, and learned of Nathan Pritikin in the 70s and realized that actually what I was doing personally in my own home with my wife was actually a bit of a therapeutic advantage for patients. So really from the beginning, I was teaching them. In 1990, when I went out and practiced, because I'm in my 33rd, 34th year, there wasn't an internet, but you could give somebody a paperback called Reversing Heart Disease by Dean Ornish, which of course has some actual urology and prostate cancer data too. So I always combine the two, but about 9 years ago, I threw the stent away and used Sprouts and treadmill desks.
Sprouts and the sort. Right?
And sleep therapy. And so now I'm an integrative cardiologist, 100%.
So you've been for 30 years.
30 years, 33 years cardiology, 46 years vegan, 46 years of my 64 years on the planet. And about 8 to 10 years pretty much completely integrative practice in Detroit, Michigan.
And so is your practice primarily, so for example, it's hard. So I'm in urology, as you know, and I'm a prostate cancer and prostate, expert, if you will. But we're always looking at everything holistically. So if I put a protocol together for my patient who, let's say, he wants to either prevent or has prostate cancer, but then it promotes him from getting a heart attack a week later, I'm not doing my job, right? It's not just preventing him from prostate cancer or dying from it. It's like, how can you live better and longer with age? So I know you're a cardiologist. Do you look at it that way, or you just focus on cardiology in your practice?
No, it's a broad practice. I mean, we talk about prostate health and dental health and cancer risk
Right.
and, stress, mind, body, but my focus is easy. I
Mm,
mean, I'm dealing with a disease that kills more people than anything else on the planet.
absolutely.
If I just stick to early identification of risk or early identification of disease and early, plans
Mm-hmm.
to avoid ever having a cardiac event, I mean, that's enough to fill my day without going into every other organ system.
A
So
hundred
I'll
percent.
refer out advanced hormonal work, advanced gut work. I'll refer out. I got enough to do. And we can talk about, you call me and say, I got John Smith and he's going to undergo some prostate cancer treatment. What cardiac labs, what cardiac tests? He has no history. Everybody needs testing. I don't care what your history is. There's too much heart disease. You can never assume. I don't care if you're 145 pounds and run 10 miles every morning. Never assume you're free of heart disease. It's just a non sequitur in my, pretty broad experience.
Joel, you and I both know, and I've spoken to a friend cardiologist. We spoke about him before we started recording, Alan Gittig, about this. And part of the conversation was, what's happening out there in medicine? Why are not only physicians, not only general practitioners, not only internal medicine doctors, but cardiologists still ordering the same 5 things to look for cardiovascular, same 5 biomarkers, total cholesterol, LDL, HDL triglycerides, and not looking beyond that, right? So, what would you say? Is it insurance based? Is it what's happening there?
Yeah, I think it's an overwhelming volume of patients. So there's no drive. My office is half empty. I better expand my toolbox to attract more patients. Most cardiologists have more patients than they need just by the nature of the disease
Mm,
and the number that are trained. Number two, it's clearly the educational system. I mean, med school education. I mean, you know it and I know it. I mean, I don't think everything about the pharmaceutical industry is innately bad.
mm,
But once you graduate and you're in practice, one of the biggest influences is what pharmaceutical company is bringing in the grand round speaker and what pharmaceutical company is bringing in a pizza salad lunch. And it's not going to be
mm.
anything usually about a new lab or CT or ultrasound or genetic panel to really expand your knowledge base. So, I mean, once you open Pandora's box of getting into integrated medicine, you realize, there's a zillion other sites to learn from and people to learn from and all. But even the preventive cardiology meetings, the cholesterol education meetings, and they're better than they used to be. They're still very much focused around new pharmaceutical approaches with, then bacon breakfasts and, pizza parties. And, it just doesn't really filter down to there's some great disconnect here that we're eating like pigs and we're promoting, cardiovascular health. And again, that's a generalization. There are obviously people wildly crazy about lifestyle medicine
Yeah,
and preventive lifestyles. The American Society of Lifestyle Medicine,
yeah.
American College, it is actually ACLM,
Mhm.
has really taken a nice jump, but it's not 5% of physicians that are actively involved in lifestyle.
I
So
find
it's
it.
frustrating.
Yeah, it is
Yeah.
frustrating. I find in the world of urology that there are a lot more people and practitioners interested in integrative urology, but they just have a hard time crossing over. Whether it's what I call the golden handcuffs, right? So you have kids in college. If once you start switching to integrative medicine, that's a
Right.
switch. You may take a financial hit for a couple of years, and some people can't do that, though they're very interested. They want to have that conversation. They want to spend more time with patients and look at things holistically. They just can't. Do you find that's a similar situation in cardiology?
Well, yeah, there are constraints. I mean, I started ordering in a standard insurance-based practice where I was seeing a lot of people every day in the clinic. You wouldn't distinguish me from any other cardiologist. I started ordering advanced lipid panels and advanced biomarkers and genetic testing like lipoprotein A and NP20, 9p21. I started doing this in the last 3 years of my standard practice. And I got it done, and I communicated to patients and gave them, extra information that was all within an insurance model. But, I had to do it in about 2 minutes when the results came back. It just made my life more difficult. And that's why I ultimately switched to give me time to really explain to people instead of plan for people. You ask the average, physician or nurse practitioner, do you have 2, 3, 4 extra minutes every visit to go over lifestyle medicine or advanced testing? The answer is they're so stressed out because they know there's 3 patients waiting in the waiting room. So, yeah, I am in a cash-based practice now. It was a very scary day when I signed the papers to withdraw from Medicare and Blue Cross and Humana and all the others. But it was necessary to do the work.
Yeah.
Yet I think it can be done in a insurance-based model. You literally need just a small modicum of maybe 10 extra tests you order and 3 or 4 educational handouts or online educational materials about. But, I haven't written a book yet, Integrative Cardiology for the practitioner. I mean, that would be a good book, or for the medical student.
I think that would be great.
I tend to write, more for the public, but that's when the revolution will happen, is when it's actually more common in the office setting.
That's great. And I think you should write that book. I'm being, selfish. I'm not a cardiologist, but I do dabble because I see a lot of men, and sometimes I give them some guidance. And I think it'll be a good deed for humanity, honestly. So I look forward to that, Joel. I look forward to you writing such a book.
He spoke the words, it shall happen.
Let's talk about biomarkers for a second. And let's stick for just a couple of minutes with the top ones that everybody orders, right? And its relevance and significance. What we're trying to figure out is, what is the best non-invasive way to determine the health of our arteries so that we can lower our risk or prevent the risk of a stroke or a heart attack? That's what we ultimately trying to figure out.
Yeah. Well, let's talk about that. And I do agree with the statement you made a couple of minutes ago, that the usual interaction between an internist, a family doc, and a cardiologist with a patient is the same lab panel they had 30 years ago. And I find it incredibly insane.
Any use, for example, I don't find that total cholesterol is like, I don't know, I've seen total cholesterol pretty high. And when we do like calcium scores or other tests, is like they're a 0. Some people even say, well, maybe not even LDL is a big deal in terms of cardiovascular risk. I like triglycerides, for example, HDL ratio from an insulin resistance perspective, which then leads to. So where is there, if any, good use with the top biomarkers that are utilized today?
So I want to back up, because you won't get most of these. Part of the reason is there is the U.S. Preventive Task Force. I think that's the proper name. That recommends what should be done in a routine visit, and then the insurers decide to use that. So, for example, about 4 years ago, they actually withdrew their support to even get an electrocardiogram on a 50-year-old annual physical with your internist or family doc. So electrocardiograms are rarely paid for anymore. And that's, not a biomarker, but it's still of some value for cardiovascular health, and, a $35 non-invasive simple test. So a lot of it is physicians anticipating that their patients' lab values won't be covered by insurance. And with just a little education on proper billing codes for vitamin D deficiency, omega-3 deficiency, family history of ischemic heart disease. Anyway, you can get these things appropriately and legitimately covered. I don't own a lab. I don't make any money from lab values. So let me even back up one more. There's 2 paths to take, and you can take both. A very famous preventive, and I believe he was a vascular surgeon in Europe, Ernest Schneider, said the best biomarker for arteriosclerotic disease is to look at an artery. So one approach is, which is hugely deficient in U.S. and Western medicine, is, you already said the magic word, maybe at age 40 to 45, you ought to go for an imaging test to find out if you're developing accelerated atherosclerosis, just like you're going to go for a colonoscopy, a mammogram, a digital rectal exam, and a gynecologic exam for uterine cancer. Maybe you should get your heart screened, given you're about 10 times more likely to die and maybe die in your 40s and 50s, and nobody does it. So, in New York City for $100 at NYU or Columbia or Mount Sinai, you can get a heart calcium CT scan, and you pray it comes back as 0. It's not a perfect test. There's no needle, no injection. There's no pain. It's not claustrophobic. There's a very small exposure to radiation, which if you get on a good modern CT scanner, it's very low exposure. And you want to come back as 0. Heart calcium CT scan. You fulfill Dr. Schneider's prediction. That's where the biomarkers become less important, because you're dealing with a person that has no overt premature atherosclerosis, and the LDL may be high, and you're going to scratch your head and say, I thought LDL causes atherosclerosis. It's a risk factor. Well, I will cover that in a minute. Or you could do a carotid ultrasound, lifeline screening, or get to a good vascular clinic like mine or many in New York City. And if you have no plaque in your carotid arteries, it's better than if you're 44 years old and they do tell you have mild plaque and thickening of your carotid lining of your arteries. So we have a system that doesn't build that in, and it's crazy.
It's backwards.
These heart calcium CT scans were developed at University of California, San Francisco, 1990. And anybody interested, there's an amazing documentary online, I think on YouTube, called Widowmaker Movie, about the development of the CT scan and how it has the capacity to grossly but very efficiently say you're high risk, you're low risk, you need all the biomarkers, you need less. Everybody needs to eat well and have fitness and try and maintain their weight and sleep well and manage stress. But some people need a whole lot more and some need a whole lot less. Some need statins and aspirin, God forbid. Some need none. And we have science that says this simple CT scan, $100 out-of-pocket expense, can do all of that in about 3 seconds and then do it again in 5 years. There are even more advanced ways now using it's called CT angiography with dye. And thank God we've brought artificial intelligence into cardiology practice. There's a term I love, precision medicine, precision cardiology. So, we can, anybody listening, you're less than $1,000 away from having a very precise characterization of what's going on internally. Dr. Schneider principle again, if you want to know your risk for atherosclerosis, check your arteries. Where for under $1,000, you can know everything we know that we might know from cancer screening or dementia screening or diabetes screening, but we've been so deficient in the cardiovascular world. So that's pre-biomarker. You might want to do the ultimate biomarker. How's my arteries doing? And there's even a concept called arterial age. You're 64 years old and your arteries are like a 48-year-old. Yes. And that's a real concept with real consequences for your longevity and health span. Or you're 48-year-olds and your arteries are like a 64-year-old. Not so cool. You need a wraparound love. Beyond that.
How do you calculate that, Joel? How do you calculate arterial age?
Usually databases. You have a burden of calcium in your heart arteries, or you have a burden of plaque in your carotid arteries. And these are precise measurements. That would be more typically found in somebody 15 years older than you in a database of 6,000 men and women across the United States.
So is there some way where you plug in these numbers online, a calculator where you plug in these numbers and it gives you a score?
Yeah, you can look at, you're probably familiar with a study called MESA, Multi-Ethnic Study of Atherosclerosis. And literally you could plug in online calculator. Anybody can use it. I use it every day in my office and tell people good news and bad news, but it's precision and it's scientific and it's meaningful, because you could have a high cholesterol and live a long life. You could smoke and live a long life. But if you've got accelerated plaque in your arteries, you've got a problem. Beyond that, there was a rise in heart attacks after World War II. Our diet got rich. The economy went up. People came home smoking free cigarettes. A lot of money went into identifying biomarkers. And that's where the Framingham study, particularly, there were others, came out and said just what doctors do every day. Check a blood sugar, or God forbid, a 3-month blood sugar called a hemoglobin A1C. Check a panel of lipids, total cholesterol, HDL, LDL, triglycerides. Then you can make ratios if you want. It's just simple math. Check a blood pressure. You're going to need a home blood pressure cuff, everybody. Number one request I have of patients, home blood pressure cuff.
What's a good one?
I have no stock, but Omron Platinum you can buy in all the big box stores. Omron Platinum's a good one. Costs you about $79. And we have them in my office just for that reason, so people can go home with one. They need one. You got to use it. And you got to use it regularly. 11 million people a year, I think is the stat, die of hypertension-related diseases like strokes and aneurysms and
Joe,
all the rest.
what's the with the Omron Platinum? They do it at home. What's the ratio where they come to your office and they're completely different outcomes, different numbers, right? So that's what I hear a lot. I go to the office, maybe white coat syndrome or something, but the numbers are completely different.
You're asking me a cutting edge question because I know you like literature. I do too. So number one, there are people that check their blood pressure at home. It's 130/80, and in the office, 130/80. It's consistent. There are people that in the office, it's 160/100, but at home, they swear, they write it down, they track it. It's 120/70. Of course, we call that white coat hypertension. And there's actually one called masked hypertension that in the office, they're 130/70, and at home, they're 160/100. And they're doing it right. They're sitting quietly, they're relaxed. They've got a cuff on their arm, and they're doing it a minute apart 3 times. So it's not a anxiety-related blood pressure spike at home, and you really focus more on the third one than the first one. So in I believe it was New England Journal of Medicine in the last 10 days, but certainly in a just brand new publication, Spain has a really aggressive hypertension program across the country. And in 203 family doctor clinics, they accumulated 55,000 people that had blood pressures done in the clinic. And then they wore a 24-hour, it's called ambulatory blood pressure monitor, which until recently was a total hemorrhoid in use. But you put a cuff on the arm, cables, and you wear a box on your belt that looks like an old-fashioned Walkman. And for 24 hours, it's getting, maybe 80 different blood pressures, not just 2 or 3 in the office or at home. They compared all that, and it's not the first time. The most predictive measurement you can have of your risk of dying of stroke, heart attack, or just dropping dead of what's called sudden cardiac death is actually your blood pressure at night. And you can't measure your blood pressure at night while you're asleep unless you have a 24-hour ambulatory blood pressure monitor. Fascinating. So I will tell you, I am not an investor, but there's an Israeli company that has just captivated my practice and my intellect called biobeat.com, BIOBEAT.com. They have a simple little patch, first in the world, patented, FDA approved. You wear a little patch for 24 hours. You feel nothing, but 100 times in 24 hours, it measures your blood pressure, and you get a report instantly. You get the daytime blood pressure, the nighttime blood pressure, the average blood pressure. I think it's a breakthrough, unparalleled, and I've had about 100 patients wear it so far in my practice. They're just developing a distribution system. It's called photoplethysmography, and they've got all the data about the accuracy, because that's always the bugaboo. What's accurate? There's the home one, is the office one.
Right.
Until you do it 20. I went deep on blood pressure, but I'm passionate about our complete absence of screening for heart disease using heart calcium CT scans, properly screening for blood pressure by home blood pressure cuffs, and now 24-hour ambulatory blood pressure cuffs supported by this huge Spanish study.
Well, we'll look into it. We'll have it in our show notes. Before you continue, Joel, because I know you can talk about this without interruption for hours and hours at a time. So I need to slow you down here a little bit. I want to get some key points in.
I think I gave you a 15-minute intro to the question you asked me. Biomarkers.
Exactly.
Okay, let me at least finish that.
Hold, before you do that, because you went into the
like 2 Italians, except I'm not Italian.
You're an Italian Jew. I don't know. That's a deadly combination there. To do the score that you mentioned, what was that score that you mentioned?
Heart calcium CT score.
Right, heart calcium CT score. So you need several readings of your calcium score. You need your angiogram of your carotid artery. You need those values to plug it in and then to get a score that's valuable. Is that how it works?
Yeah, the heart calcium CT score is actually a CT scan. Unfortunately, everywhere except the state of Texas, you have to pay for it, but it's about $75 to $100. Mm-hmm. In Texas, it's an insurance-covered benefit, and if you watch the Widowmaker movie, you'll see why. It's fascinating. You do need, in almost every state, not everywhere, but you need a doctor, a nurse, a PA's script.
Sure.
It says, heart calcium CT scan, self-pay. Doesn't involve your insurance company. No need for pre-authorization. Test takes 2 seconds, and it comes back 0 It's a good news, warm, fuzzy feeling. And your arterial age is going to be lower than your driver's
And what's
license
the
age.
number that will scare you? I know that some low numbers
Yeah.
are okay.
Brand new science published 3 weeks ago, but it's really consistent with 33 years of science. A calcium score over 300, and I'd say 10 to 15% of people listening to this YouTube podcast are going to have a calcium score, silent disease, over 300. It can go to 2,000, 3,000, 4,000. But if your calcium score is over 300, but you're playing pickleball and say, I feel great, you have the same risk of dying prematurely as somebody who's already had a heart attack. So you need a dietitian and a baby aspirin and probably prescription medication, and you need nutritional education, and you need a fitness plan. You need cardiac rehab with Dr. Ornish or the Pritkin program. You need a lot of attention. So that
Thank you.
number can stick in your head. But if your number's 33, I care, because you've got atherosclerosis and you're way more risk than me, who has a calcium score of 0 for the past 30 years.
At 64.
At 64, I've had a CT angiogram. I have no plaque in my arteries. That's the power of parsley. The power of parsley.
Parsley. That's another book.
Sounds like a Prince song or something.
Arterial age. That's what thank you for that explanation. That's what I was referring to as well. Arterial age. To get your arterial age, you got to plug in some numbers. And so all these numbers are from a CT score or angiogram.
The most common way to do it is a heart calcium CT score for $100. You can get your arterial age. If you find a good center that does carotid disease, like we do in my clinic, but it's available in New York, and you got to hunt around a little. My reports will tell a person, you're 48 years old, but your arteries look like a 61-year-old. And we work on it, and it is reversible. You can improve on it within 12 months, and certainly within 5 years, make major improvements. You can get younger. Your vascular system can get younger.
Sure.
Your erections can come back, guys. They really can.
Sure.
Just put a little parsley on your plate, please. Parsley over bacon. Biomarkers.
Let's do it.
Okay. So we learned that, high blood pressure, high cholesterol, high blood sugar, mom, dad, brother, sister having a heart attack, stroke, bypass, and smoking, the big five, we learned in 1960. That's medicine in 2023, sadly. So ask for a couple more. High sensitivity C-reactive protein, a blood test that measures inflammation in the blood vessels. Some studies say more important in predicting heart attack and stroke than even LDL cholesterol, which is pretty important. But high sensitivity C-reactive protein, simple blood test. Every lab does it, from Quest to LabCorp to your local hospital to your family doctor does it. Ask for an advanced cholesterol panel. It's called an NMR, Nancy Mary Radish NMR
profile.
Lipid profile.
Yep.
Little bit more advanced, particularly if you're a bit portly, pre-diabetic or diabetic. It's more accurate in that setting for sure. It's not necessarily an enhancement to everybody. I like a blood test. This is the last cholesterol one. It's called ApoB, APO.
Yeah, I was hoping you mentioned that.
One number that gives you all the nasty particles in one number, and numbers should be less than 90, less than 70, less than 60. If your
lower, better.
If the lower, better, particularly if your calcium score of your heart's not 0, lower, better. You can do a diet. You can do
How low can you get your ApoB dietarily? I've struggled with that with patients.
Well, you're asking an interesting question. And what my current explanation to patients is, imagine the NFL made a football field 150 yards long, and here I am with sports again, so I'm going to step in poo. But, it would be harder to score a touchdown. You'd have less people slamming the football. We used to take a patient who had heart disease, maybe bypass, heart attack, high calcium score, said, get your LDL cholesterol under 100, standard football field. Then we changed it, get your LDL under 70. We made the football field longer, harder to score, harder to get there. And diet doesn't do it as often as it used to because the goal has changed, not the diet. And now we're talking that actually the international guidelines for people who have advanced heart disease, bypass, heart attacks, high calcium scores, angina, it's actually LDLs of 50 or less. As safe, good for the brain, good for your testosterone, fine for your sexual
hard
function.
with just lifestyle
So
and
now
natural.
we're getting it, all that parsley and all those black beans and all your oatmeal. It's harder than ever to do those aggressive goals with diet alone. So the diet is still a foundation of good health for prostate health and prostate cancer avoidance and every other overlap between the heart and your organ system. but it's just going to take usually a supplement or possibly a low dose, super low dose prescription drug. So let me keep going. Lipoprotein A. I will shamelessly say, because it's sitting right next to me, but there's the word on the screen. Lipoprotein little a.
That's a
I've written a
shameless
book.
plug. I'm glad you did it.
Shameless plug. Shameless plug. Shameless plug. Also full of about 70 amazing recipes.
So that's for those that are not watching on video and those that are listening. This is Dr. Kahn's book, Lipoprotein A. What's the subtitle there?
The Heart's Quiet Killer.
The Heart's Quiet Killer. So we'll have it on our show notes as well.
100% of people make LDL cholesterol, but 25% of people have the ability to make two cholesterols. And as you imagine, that might not be so cool for your cardiovascular risk. The second one has that obscure name, lipoprotein little a. Although there's been an explosion of articles in the last year, Men's Health and New York Times and LA Times. It's not as obscure as it was when I wrote that book 2 years ago. And it's a frustrating little particle because there's no approved pharmacologic or dietary lifestyle agent to lower it. But I think a good thing, 3 pharmaceutical companies have agents that'll be out in the next 2 years. So you may actually have to take your Lipitor and your Pelacarsen, that's the name of one of the 3 coming down the pipeline. I can lower it with niacin and other manipulations. So I do a pretty good job of getting my patients' lipoprotein A down because I'm not paranoid about using an old-fashioned vitamin called niacin because it does
cause a little flushing.
A little. I took 1,000 milligrams this morning and was a little beet red faced about an hour ago. I like it, but you can lower all kinds of cholesterol particles with it. Any other biomarkers, vitamin D level, D like David, omega-3 level. Number one nutritional deficiency in my practice is a low omega-3 level. They're vegan. They don't like fish. They don't like salmon. They don't like sardines. They don't eat chia. They don't eat flax. They never heard of hemp hearts. And they're just super low. And your brain is just like sucking, gasping for a little membrane construction molecule called omega-3, EPA, DHA. That'll do it. You don't have to do too much more.
I'm surprised you didn't say things like TMAO.
Okay. TMAO, I would put a category down. It's a fascinating story, and I can do it in under 60 seconds.
What does it stand for? And tell us about it.
Yeah, trimethylamine N oxide, TMAO. When you eat, this is all Cleveland Clinic research since 2011, but they were hunting. They're always hunting. Dr. Stanley Hazen is his name. Is there a new particle in the blood that might be causing people to die of heart disease and strokes and aneurysms we haven't found? I mean, because it can't be just cholesterol and blood sugar and blood pressure. So they found this molecule, and they found quickly, if you eat egg yolk, it's rich in choline, and choline gets converted by your gut bacteria through your liver to make TMAO. Mm-hmm. And if you eat red meat, it contains L-carnitine, and the same pathway occurs. And if you check in vegans, you don't find TMAO. And Dr. Hazen is no vegan. This wasn't pro-vegan Cleveland Clinic research. It was just research. And they quickly found the higher your blood TMAO level, the more plaque you had in your artery system. And now the more fibrosis you have in your kidneys. There's a very strong TMAO kidney disease connection. If you're diabetic, if you have heart failure, if you have early memory issues, the higher your TMAO level, the worse the disease will progress unless you make the changes. They just reported, I mean, everything's brand new research. The higher your TMAO, the greater your chance of an abdominal aortic aneurysm. And they're working hard on a blocker. Of course, you can block it by stop drinking energy drinks that are rich in L-carnitine. Many of them have it, and choline, or at least get a small amount in your diet, not a massive amount in your diet. Have 1 egg yolk a week instead of 10. I mean, and you can ask for a blood test. It's available at Quest Labs, LabCorp.
But that's TMAO, not your top tier. Your top tier are the ones you mentioned. So it's C-reactive protein, NMR lipoprofile, APOB, and lipoprotein little a.
Yeah, that would make a big dent in identifying a whole lot more people at risk. But TMAO is a fun one, because there is actually, a pretty simple path to bring it down if it's high. And God knows. And, a lot of people are going to the vitamin shop. They read an article and they're buying carnitine, they're buying choline. And I'm not saying it's always bad, but if your TMAO level's sky high, like many of my patients, you might want to cut back.
It's tough. And this is where it gets a little tricky, because sometimes, and we'll talk about that in a second, because I want to put a bow on the biomarkers. But sometimes it's a matter of a trade-off, living longer and quality of life. It's almost like you can't have it all, right? Because you need choline for brain. By the way, a lot of association with choline and prostate cancer, right? A lot of correlation.
so much
Right.
so that I cannot ignore it. And but you need choline and phosphatidylcholine for brain function. Your brain really won't function without it. So it's a fine line.
There is a fine line, and I encourage people to, talk to their doc and get the blood test and maybe bring the dose of choline, L-carnitine, and supplemental sources. Look at your energy drink if you're drinking energy shots, and maybe bring it down a bit if your TMAO is high. Berberine, a popular agent for lowering blood sugar, blood cholesterol, it's now being called nature's Ozempic. People lose weight on berberine. Can also lower TMAO. That's brand new data.
That is brand new. I've been using berberine for over 25 years as a naturopathic doctor for many things.
Yeah.
And look, and now we know that it brings down TMAO as well.
TMAO.
Homocysteine?
Yeah, that's probably a good thing you brought it up and an omission on my part. Homocysteine, Homocysteine, is a amino acid that, again, has a role in the body, but like many things, too much isn't necessarily better. There's a sweet spot. If you eat a very red meat heavy diet, your homocysteine might go up from the additional L-methionine in the diet. If you have a genetic defect that you check and I check called MTHFR methylation status, and finally, if you're deficient in B12 and folate, it might be high. It's a real sensitive to B12 deficiency. And, probably 60 years of data that a super high homocysteine is related to worse arteries, worse erectile function, greater cancer risk, greater brain dysfunction. So it's such an easy one to treat with diet changes or simple B complex vitamins. It hasn't been accepted by the standard medical community. Of late, folate supplementation is associated with longer lifespan, better brain health, better cardiac health. So it's creeping in because the science is undeniable that you bringing homocysteine down with folate, but you and I know it takes usually more than folate. It takes the whole
B6, B12, and all these things.
Right.
But to be clear, you're referring to folate, not folic acid.
Right. Not a big fan. And, nobody's made this clearer than Ben Lynch, another naturopathic doc, that, when you buy your cornflakes and they're fortified with folic acid, it may actually gum up your metabolism. When you're eating leafy greens, they have a more natural version. And if you get better vitamins than the average, they'll have folate or methylfolate, and the body can metabolize that and bring down homocysteine without an excess of folic acid, right?
All right, so let's talk about, and I'm not putting my boxing gloves on because I think we're aligned for the most part, diet, diet and cardiovascular disease. And the reason why, in case there are a few people that don't know you, Joel is a huge plant-based doc where he's very vocal about it. He's been vocal in many other popular podcasts, and he has had numerous debates on the topic. Joel, let me give you some context that you may not know.
And now let's give a little love to our sponsor. We're here in Heart Health Month, February, and this is the Heart Series here at Dr. Geo Podcast. And I want to thank our sponsor, Calroy. Calroy produces two excellent dietary supplements. One is called Arterial Sol HP, and the other one is Vasconox. And both do an excellent job in supporting cardiovascular health. Arterial Sol HP helps with the production of the endothelial glycocalyx. You'll learn about that with Dr. Miles Spar in this series, where you need that particular lining in the endothelial cells to help your heart and your blood vessels and vascular system work well. Vasconox works in the proper production of nitric oxide to, again, help your vascular system and your heart stay nice and healthy. Arterial Sol HP and Vasconox make the perfect combination for vascular support. Give your glycocalyx and nitric oxide production the attention they deserve. Heading over to the website, calroy.com/Dr. Geo. That's Calroy, CALROY.com/DRGEO. I'll see you there.
Throughout my 25 years journey of natural medicine, I've done everything from Atkins diet to zone diet, including plant-based, only plant-based, vegetarian, raw food. I've gone through the spectrum, both for experimental reasons and because, hey, I'm going to do this for a living. Let me know. I always want to know how difficult or easy it is for the patient or my audience to do what I'm asking them to do. I want to do it before they do it. Fasting. I want to do fasting so that I know what they're going through, whether it's intermittent fasting or a couple of days of fasting. I think plant-based, and when the floor is yours, you can kind of course correct wherever you see fit. My definition of plant-based is not necessarily exclusion of animal products. It's plant-based, is mostly plant-based, 60, 70% plants. And I think if people do that, well, the first dietary rule that I have for most people is, we're all eating too much. Let's eat less. Then it's the conversation of what to eat. Plant-based to me doesn't mean the exclusion of animal products or fish and things of the sort. And we could talk about why I think that's important a little bit. Actually, we could talk about it now a little bit. There's like I mentioned before, sometimes it feels like a trade-off with longevity, quality of life, and performance. So if I want to live longer, I need to do this, but it may not help my performance. One of the things that I care about, and as I see aging men, one of my biggest concerns, certainly other than cardiovascular disease, is sarcopenia. That's natural muscle wasting, which then it leads to metabolic problems and eventually weakness, physical weakness, and eventually broken bones. Broken bones after a certain point is deadly, right? A 30% mortality rate after a certain age. So your approach as a plant-based doctor is plant-based. What do you feel about that definition of it doesn't have to exclude certain foods? The other thing is I want people to be inclusive. I want people to find ways to, improve their diet reasonably. So if they love their medium rare, all right, well, let me show you how to do that. Take it away in whatever direction you want. I think you get the point, and I think our audience is going to benefit from this.
So again, disclosure, I've been completely 100% whole food plant-based for 46 years. So I don't have an egg a week. I don't have a piece of fish a week. I don't have a piece of beef a week. There's nothing that isn't a plant that goes in my body. And 99% of it is organic, whole food plant-based. I don't eat Impossible Burgers and Beyond Meat burgers. I feel great.
That's a great point, by the way. Thank you for saying that, because a lot of people think that's part of the problem. A lot of people don't really know how to do a plant-based diet, I think. So that's a big deal.
When I calculate my vascular age, arterial age, when I calculate my epigenetic ages as a little bit of a biohacker like you do, they're all very favorable. Is in the world of cardiology, if you take the foundational studies, I want to reverse or prevent, but let's take reverse. It's harder to reverse a disease than it is to prevent a disease because the disease is present. All the reversal heart disease data, we always need more, but all of them, that's not true. Most of them are 100% plant-based, no exception. That would be the famous randomized studies of Dr. Dean Ornish, who's now working on reversing brain disease in an ongoing study. Dr. Esselstyn at the Cleveland Clinic, the famous Pritikin Longevity Center in Miami. But to be actually fair, 19 meals a week in the Pritikin program are whole food plant-based. They allow patients to have 2 meals a week, maybe bison, maybe a piece of salmon. So that's nearly completely plant-based. The heart disease.
When you say reversal,
I'm talking people having angina pain on the treadmill that it goes away in 5 weeks because they've altered. The worse their diet is at the beginning, the quicker the response is going to be to flooding them with leafy greens and berries and whole grains and legumes. They're going to respond quickly. And if we actually do advanced imaging, not the calcium score, you got to go to the more advanced CT angiogram or maybe the carotid study, you can actually see plaques start to shrink and arteries start to open. And that's why they're symptomatically feeling better. Their erections come back because their pelvic vessels are improving. These are all scientific endpoints that are undeniable.
Yep.
And they're largely whole food plant-based diets. If you shift to preventing disease or just hoping that you live a long life with good health span, there's a little more wiggle room because it's not 100% guaranteed in the science that a vegan lives longer than a pescatarian, and a pescatarian lives longer than a lacto-ovo vegetarian, and they live longer than an omnivore. The best data maybe is from Loma Linda and the Seventh-day Adventist, very large database, where actually pescatarians, largely plant-based with little fish, in a non-randomized study, just a good database, lived a little longer than the vegans. But they all lived longer than those that ate a pretty animal-heavy diet in studies published, I think, in 2013 and many others. My fallback for most nutrition is go read Dr. Walter Longo and his body of science, professor of gerontology at the University of Southern California, the Keck Medical School. Read his book, The Longevity Diet, which was published in 2018. Learn about his 5-day fasting mimicking plan, which of course you know about, and you mentioned fasting. And, Dr. Longo, after studying, the number one funded science nutrition researcher in the United States, $33 million of NIH funding, at least, I think it's more than that now, has gone into his research lab, and you and I are paying for that. And it's a flood of productive data that he's produced, but he eats 18 to 19 plant whole food meals a week. He does tend to eat 3 meals a day. He's not a big believer in shrinking your eating window into a super small window. And he eats 2 to 3 pieces of fish a week, very similar to the Loma Linda data. So I think if somebody starts there, 18 meals a week, the Seventh-day Adventist, Dr. Kahn, the cardiologist, Dr. Longo, the eminent nutrition scientist, say should be grains and beans and fruits and vegetables and as close to nature as possible. And if you want to enjoy 3 meals a week that aren't in that route, just don't make them junk. I think you're in a good space. I don't choose to do that, but I don't yell at my patients that adopt a Mediterranean diet where they're shifting their red meat over to salmon or sardines, and they're shifting their butter over to extra virgin olive oil, and they're adding in more legumes and big arugula salads and getting out and walking after dinner. I welcome their Mediterranean diet, except if they're really advanced heart disease people. I'll just point out to you, this is totally random and opportune timing, but I keep up on the literature with the same kind of passion you do. There's a publication this week at the American Society of Clinical Oncology from Harvard that men with prostate cancer, but a good prognosis, predicted the closer their diet is to a whole food plant-based diet, the better was their energy, body mass, sexual function, and longevity. And it was everything Harvard does has a lot of patients. This happened to be 3,500 men with predicted to be good outcome prostate cancer. And when you change the diet more and more plant-based, like we're talking. So the question is, people do better, I believe, with strict rules versus loose rules. Well, okay, 18 meals a week, plant-based, 3 meals a week is in your territory to examine what you're going to do with it. And I think we can all have good health with that plan.
Well, I love that plan. That's pretty much what so amazing. That's pretty much what I prescribe as it relates to red meat, which is the boogaboo with people, and plant-based, and certainly we have people that are completely on the opposite spectrum, the Paleolithic movement with one of our colleagues, Jack Wolfson, which amazingly, you guys, he's another cardiologist, and you guys are amicable. The research that I've read on the consumption of red meat is not that necessarily that red meats are bad or promotes dying prematurely. Processed meats are definitely what keeps coming up the highest there. And why do I say that? I think you could, going back to sarcopenia and muscle wasting, you need certain amino acids. So when they say, well, no, you can do a complete protein, you can have a complete proteins with a plant-based diet. Sure. Yeah, that's true. But specifically what you need for muscle synthesis and protein synthesis in muscle is leucine primarily, and then the branch chains, isoleucine and valine. You get that very nicely with red meat, not so nicely in a plant-based unless you include fish. And again, at the risk of being repetitive, I see in aging men the main problem to be muscle wasting and physical weakness, to be a major problem that leads to many other problems. What is your opinion? And again, I'd say, look, no processed meats, but give them some guidance with some type of red meat, whether it's grass-fed. That's another story.
Well, I think everybody agrees. That's where Jack Wilson and I can get in, and we're very good friends and colleagues, but we disagree on many topics. We all agree that processed crap, and we know what crap looks
That's right.
like. It comes in the frozen section of the grocery store. It comes in a paper box, comes with a plastic wrap. You got to pop it in your microwave. You're driving through your car and you're grabbing a bag through your window. And, there's so much crap out there and people are eating so much crap. And in the vegan movement, now there's vegan crap everywhere.
Yeah, the
and
fake
there's
meat,
always
all the fake meats, right, Joel?
fake meats and imitation everything, and we got Bill Gates wanting to feed the world GMO fake food in general. I mean, we all agree that's toxic choices. And even in the plant-based world, even in the study I just mentioned here with men with prostate cancer and their diet choices, an unhealthy plant diet is as bad as the general diet. It takes harder work. You got to actually open a can of kidney beans and make a bean salad. You got to get real old school Italian, peasant food,
Right.
and then you're in a good place. So we all agree junk is to be eliminated as much as possible from the diet. Then you get into versions of clean diets, and you got a paleo clean diet and a ketogenic clean diet and a Mediterranean clean diet and a whole food plant-based clean diet. And, we can talk about that, and there's diet wars, but let's focus on getting junk out of the American diet. It would be huge.
If you go from a standard American diet to
Right.
any diet,
any of those, you've just upgraded. And that's the only reason you could possibly explain why people aren't dropping dead of the carnivore diet. It's an abysmal choice, absent all cardiovascular safety data, but it's better than running over to Burger King and getting a couple, triple
or
Whoppers.
even just a lot of just bread. And so what I've seen with vegans, and of course, the problem is that most people are not doing it right. That's the problem. I get that. It's hard to do it right, Joel. And I am in this, I'm in it. And it's very difficult to do it right. What I see with most vegans, I find that a lot of vegans are actually unhealthy. They do have in my opinion, a protein deficiency, whether because I see it with their nails or their muscle mass is really low or their immune system. You need amino acids. And they're just become more starchitarians oftentimes. So they're eating simple carbs and things.
But I just want to finish up with your sarcopenia comment. I started to watch this come on, social media and other locations in the last 18 months. And you're probably familiar with the term muscle-centric diet. And my friend and colleague, Gabriel Lyon, and others, I was very honestly reading Mark Hyman's new book. I would call Mark a friend. I wish him happy birthday every year by texting him and all the rest. But, he's got a book out called Forever Young on longevity, and I'm reading it, and I spit my tempeh burger out because there's a sentence that says if you want to build muscle, you have to eat muscle. And, you're a very scientific person, Dr. Mark Hyman. And he did reference a study in 2014 I wasn't aware of amongst all the other data. But I mean, I'm friendly with so many vegan bodybuilders that are winning awards and on covers of Muscle and Fitness magazine, and they're natural, clean bodybuilders. They're not using
So they're not using steroids.
They're just lifting a hell of a lot of weight every day. And so I got interested in this topic, and I'll just tell you real quick. There's at least 6 articles published in the last 18 months that are small randomized clinical studies. We took sedentary 30-year-olds and put them in the gym for 12 weeks on whey protein or fava bean protein, on a meat-based diet or a whole food plant diet, and analyzed their strength and their increased capacity. And all these studies have shown equality of advancement. I think it's the weights. I mean, these are pretty well done plant-based diets and pretty well done research omnivore diets. I mean, crap is crap, but the capacity to have good physical fitness and muscle strength is there if you get in the gym and lift the weights and have a broad, colorful diet. I mean, I'm a fan of tofu-based, soy-based products like edamame and tempeh and tofu. It gives you every amino acid that you could possibly want in a single food.
How's the absorber? So as it relates to amino acids and proteins, it's not the content of the food, is the ability its bioavailability. It's called a Diaz score. And so there's a score there. So my understanding is that, for example, soy foods, while they have a lot of these amino acids, the Diaz score is actually low relative to like whey protein or something like that.
Yeah, but yet, in the last 6 months, a nice randomized study of whey versus soy protein in athletes training in a gym, no difference. I mean,
Did they
real
measure
world.
muscle, what's called fat-free muscle index?
Yeah, I'm not sure. I think one of them actually did muscle biopsies to look at.
That would be a good way. Yeah, I think.
Architectural structure and enzyme activity, and I'd have to pull
Mitochondrial
it up.
activity.
There was in the last 2 weeks a randomized analysis of actually cardio, of runners, of racers, and the improvement over time. It's called the NURMI study, if anybody wants to look it up, NURMI. Runners, long distance racers on a vegan diet improved their performance as much as omnivores. And they actually had about 250 people. So that's more than your average small little study. So and it's always the question: what is the meat-heavy diet coming with it? And how clean is it?
Correct.
You got to work as hard to eat a healthy meat-heavy diet as you're going to work as hard to eat a healthy plant-forward diet, and you're going to have to be a qualitarian. That's a Mark Hyman term.
A qualitarian. That's right. It is a Mark Hyman term.
You're going to want to pick organic over non-GMO over just conventional if you have the choice and the budget. I mean, you got to be a bit of a snob about all this stuff. They're all elite diets. I mean, that's the problem. 80% of America is eating mindlessly and a toxic diet. And the 20% of us fight nonstop. And, we're choosing our version of a little bit more expensive. It doesn't have to be more expensive, but it typically is.
It typically is.
Grass-fed beef is more expensive.
And even look, local farmers market here in New York, maybe it's New York, but things are more expensive than, a Big Mac.
Yeah. So I'm open-minded. I mean, I've recently added 2 grams a day of creatine to my supplement program.
Yeah.
Because there's 2 studies. I did my podcast on this.
Sure.
That vegetarians may be low in creatine because it does come from largely plant-based sources, and athletes that are training that supplement it with creatine on a vegetarian or vegan diet may benefit. I've recently added, although not so recent, 1,000 milligrams of taurine a day, a very widely available, inexpensive amino acid supplement. One, the sources of taurine in a vegan diet can be a bit deficient. There's not a lot of data, but there's some new longevity data about taurine as a potential low-cost longevity supplement. So, and it also lowers blood pressure and improves cardiac function. So I've been using taurine in a lot of my congestive heart failure and hypertension patients with good results. And now with this new kind of flashy headline, new inexpensive longevity agent, although it was animal studies that showed they lived longer with additional taurine. We don't have a great human study yet. We have a hypothesis and a basis to believe it might be. So I'm a supplementer of whole food plant-based diets.
Yeah.
I don't think it's a deficiency in saying it's still an advantage for certain health conditions and potentially better for the environment and potentially kinder to the world. I like to bring up just, I know there's 1,000 directions we could go. I have a new friend on the planet named Brian Johnson. And some people might recognize his name, Bryan Johnson. He's the guy that sold Venmo for $800 million. And he's spending $2 million a year to try and create a plan where he's going to live the longest and healthiest of anybody on the planet. And he's just everywhere lately on the news, social media.
Yeah.
It's a very serious endeavor. He's got a team of 30 advisors. He's got a home medical clinic in Venice, California. He's not taking this lightly. So we bonded a bit because he chose a whole food plant-based diet with 2,000 calories a day of black lentils and mushrooms and greens. And
the 2,000 calories a day is also intentional for longevity purposes.
Yeah, and it's all published. If you look up Brian Johnson and something called the Blueprint Project, everything he does every day, every supplement he takes every day, every blood test.
He's very, I've seen him being interviewed, and so he's very focused, let's just say.
Very philosophical and intellectual. And, his current business project is a brain AI project. And it's like listening sometimes to Elon Musk talk. It's a level of, I think, intelligence beyond my average conversation about lipoprotein (a). But anyways, I think it's a statement that a guy with every resource in the world, economically and research-wise, chose a whole food plant-based diet as an experiment in longevity and an experiment in cardiovascular optimization. And, his biggest concern he discussed with me was, how come at age 45 I can't get my peak heart rate to 193 like my 18-year-old son? And can you help me get my peak heart rate? I mean, this guy is so focused on data.
Yeah.
I said, I don't think I want my heart rate at 190.
That's right.
I'm
Do
doing
you
something
want
either
to
very
live to
fun,
150
doing
years old?
something very fun or very wrong. If my heart rate's 193, I'm probably being chased by the police.
That's right. You mentioned you take carnitine. Thank you for saying that, because I don't necessarily, my job is not, if you're already vegan, my job is not to convert you to anything else but what you're doing. And my job is to make that a healthy vegan diet. So I do recommend carnitine. I have recommended branching amino acids to older patients who are
Right.
Vegan, and B12, right? Of course, you would do B12.
Yeah. Yeah. Right. There's some simple now. There's probably 5 companies. I work with one that make a nice multivitamin specifically for vegans to fill science-based potential gaps. A little iodine, a little selenium, a little vitamin K2. I would add now creatine and taurine, to potentially a expanded vegan support vitamin. It's fine. There's lots of things you're not getting, like a high TMAO level and a high added saturated fat content and something called new 5GC, which may cause inflammation. So it's a trade-off. There is, just on the last maybe circle around this protein topic, I tend to go back to Walter Longo, and they published in 2014 and 2016 an analysis of protein intake and all-cause mortality and stroke and heart attacks. And it's odd data because before age 65, low protein intake was associated with better health and less disease conditions and longevity. And over age 65, there was a bit of a flip in the data when they cut the data by age. And it looks like you said, in your seniors, you focus a bit more on protein support. But what Dr. Longo talks about is still well below the national recommendations. It's like going from 0.4 milligram per kilogram protein to 0.6 when you're over 65. He's not even talking about the USDA
1 gram,
0.8,
1.2 gram,
or the 1 gram up and up, 1 gram per pound
per kilogram. Yeah.
Wilson, well, they switch over to pounds.
Yeah, 1 for 1, right?
Which is a high number. So, top scientists don't completely agree, but there is a downside.
Actually, some top scientists do agree with the U.S. There are guys like Lane Norton and all these guys, PhD guys. Right. Supplements, what kind and for what? Give us an overview. This could be another podcast, I know, but give us an overview.
A whole nother podcast. I would just say, fundamental question: is it just expensive urine, or is it a benefit?
I would say yes. I would say yes to both. Is expensive urine because your body's going to get rid of what it doesn't need, but you want to saturate your body with all the good things before it comes out in your urine.
I'm actually impressed, just to fall back again. Brian Johnson publishes the 105 supplements a day that he takes on this longevity journey. And he does it for $10 a day. And he actually publishes exactly every brand and every capsule that he buys. And most of them are right off Amazon, and they're pretty good quality choices. I'm impressed it's not, $100 a day. That's a couple Starbucks worth of multivitamins. And few of us are doing 105 vitamins a day. But it's an interesting list that's on his Blueprint protocol website.
A cardiovascular disease to reduce the risk of arterial sclerosis and those things, or does it depend on, do you do red yeast rice when LDL is high as opposed to a statin? What's your approach?
It's a whole nother conversation, but I'll just give you, kind of randomly my top ones. CoQ10, which is also coenzyme Q10, known as ubiquinol or ubiquinone, but CoQ10, let's call it that. There's a Swedish randomized study that if you're 70 and older and you add CoQ10 to your diet, you actually reduce cardiovascular outcome and mortality. And it's a good study and everybody ignores it. Certainly if you're on a statin like Lipitor, there's huge biochemistry to say you should be taking CoQ10.
But good to take regardless if you're on a statin or not.
And if you're over 40, I think you should take CoQ10. There's good randomized studies in congestive heart failure that adding CoQ10 improves outcome. All cardiologists ignore that data. I use CoQ10 at very high doses in almost every patient I have. Take it myself every day.
What's high dosage?
400, 600 in my heart patients. Yeah, a couple 200 milligram on a daily basis would be fine. I like one, this is going to surprise some people, called Glynac, Glynac, which is either you take 2 pills or you find it together. It's glycine plus N-acetylcysteine. There's actually now maybe half a dozen human studies, let alone animal studies, that older, frail people with cognitive problems, muscle strength problems, balance problems respond incredibly well. And these are double-blind randomized studies to Glynac. And again, in whole food, plant-based vegan eaters, glycine may be an issue because it tends to be an animal-sourced amino acid. So glycine also helps you sleep at night. So I take 1,000 milligrams of glycine, and I take, 900 milligrams of N-acetylcysteine. These are inexpensive, safe, available vitamins. I like that there's some human longevity data. I'm big into spirulina and chlorella, which aren't really supplements, they're really food from algae sources, but the amino acid content, the micronutrient content, the pigments, the phytonutrients, the anti-inflammatory support, and also I'm big on them. I mean, I take a lot of supplements today, but I'm trying to not make the list.
Particularly for I would say for cardiovascular disease that you would highly recommend.
Vitamin D3 with vitamin K2 for some cardiovascular and bone support. I personally eat natto beans. There's a company called New York Natto you can buy online. I like their little beans. I'll give them a little plug. But that's a source of vitamin K2, but you can just take it. Some source of omega-3 could be a lot of chia, flax, hemp, could be an algae-based omega-3, could be a fish, sardine, anchovy, herring-based omega-3, or get the blood test first to see if you're deficient. I mean, those would be, and magnesium does wonderful things for so many conditions, from blood pressure to palpitations to
wouldn't you say magnesium is probably the top mineral for, you get a lot of bang for your blood pressure. You get a lot of bang for your buck from a cardiovascular perspective, for sure.
Safe as can be if you don't have advanced kidney failure. So magnesium's always on my to-go list, and it's inexpensive.
It's inexpensive.
It's intimidating. Go look for magnesium glycinate or magnesium taurate. These are the way it'll be labeled on the bottle, but it still could be pennies a day to get 400 milligrams. Or I tend to take it twice a day. It helps me sleep at night and keeps my blood pressure very normal, which genetically I'm not supposed to have normal blood pressure by this age. So I work hard at.
I saw a picture of you with your son. You guys don't look, either he's looking older or you looking younger, or both.
Yeah, there are 3 kids and they're all pretty different. We have 2 vegan children and 1 paleo child. Love them all.
You still love him? You love the paleo child? You have not disowned him?
He's even a lawyer. He's a lawyer.
Boy.
So it's so difficult. No, he's a great kid. He's absolutely.
Hey, last question, Joel.
Yeah.
Statins. That's the statin wars. Some people would say, some hardcore natural integrative doctors would say, no way, no how. I think Jack Wolfson is one of them. No way will I ever recommend it. Others would say it depends. Others would say absolutely it should be in the
Bullshit. Excuse me. I sneezed.
It should be in the. Others would say it should be in the water, and everybody should take it.
Just dispel number 1. It's not an economic conversation. 7 of the 8 statins on the market, and really the 8, they're all generic and they're pennies a day. And, the generic companies may be making a penny. I mean, in the day when these were released, and there's a whole new family of new cholesterol-lowering medications that are very expensive and require insurance pre-authorization. But it's not an economic conversation. So it should be strictly, at the time, Lipitor was the number 1 best-selling drug in the world and created billions of dollars in sales. But that's not a relevant part of any conversation anymore. Statins disturb our biochemistry. They lower our production of coenzyme Q10. They may cause some rise in blood sugar. Certainly, some people get brain fog and some people get myalgia, muscle pain. The majority of people, including some recent nocebo studies, placebo studies, that as many people in well-done studies complain of muscle aching on a placebo of statin as they do on the statin. I think that's not completely true because I'm very careful to monitor for blood sugar changes and mental status changes. Everything's reversible there's a very rare syndrome I just discovered in the last year where you can develop an antibody to the enzyme that helps you make cholesterol after you're exposed to statins. And that seems to be a more permanent problem. All the other problems go away when you stop the drug. So you just ask the patient how they're doing and you monitor blood work. And
can CoQ10 offset some of that?
Well, it offsets the blockade of producing CoQ10, of course. Like when I check a CoQ10 blood level, which is very available and easy on a patient on a statin, it's ultra low. and then I put them on CoQ10 and it comes up in a normal range. Some of them will lose their brain fog. Some of them will lose their muscle aching. Some of them that experience a bit of a rise in blood sugar, maybe they're wearing a monitor, maybe they're just having blood testing, or maybe they're poking their finger, will notice that their blood sugar is returning towards their baseline. So yes, some of it is reversible with CoQ10. There is another interesting nutraceutical called GG, geranyl, that also may help allow you to take a statin. There's a product called GG Pure I use in my clinic, but allow you to take a statin with a lower exposure to side effects. But when you take the wealth of the world's literature since 1983, I think a study came out called the 4S study, and I think I got that year right. It might be 93. I think it was 93, actually. 4S study that showed in people with extremely high cholesterol and heart disease. It was a bit of a biased sample. I mean, that on a statin versus placebo, there's a dramatic reduction in all-cause mortality. It all depends what population you pick. If you take a population of people with a heart calcium CT scan of 0, you're going to have to study 1 million people to find 3 people that benefit from a statin. And that's even the statement of the American Heart Association. There may be no role for statins in people that get the heart CT scan and have a favorable result, or get the carotid scan and have clean, young arteries. You're not treating a disease. They don't have the disease. You don't give chemotherapy to people that don't have prostate cancer. Don't give a statin to somebody that you've proven has no vascular disease. But in people with more advanced problems, given now that we're shooting for LDLs of 45, 50, 40, 40, and people with advanced disease.
APOB, we want that to be as low as a newborn. At least that's what some people are saying. There's only...
Well, that's exactly. That a newborn may have an LDL cholesterol of 25. And even, a doctor I've not met, but listened to, Peter Attia, MD, talks a lot about if you could maintain your teenage LDL cholesterol through the rest of your life, we'd be abolishing the majority of heart disease. And many reasonable people would agree with that if you could do it safely. And it's not necessarily going to be easily accomplished with nutrition alone. But, I'm not talking about putting teenagers on statins, God knows. I'm very low dose. I'm very selective. My current protocol, almost always, there's a second prescription drug called ezetimibe.
Yeah.
It used to be called Zetia. There's one dose. It works completely different than a statin. And in my practice, I can use the lowest dose on the planet of a statin with this second drug in a synergistic combo and get those wonderful LDL levels in a patient with advanced heart disease that I otherwise could get only with a moderate or high dose. And a randomized study in Korea has shown this is the optimal approach. And I just knock it out of the park when you use that combination, because people feel good. They're glad they're on a low dose and their numbers really look good.
Man,
that was the last question. I got to go, man.
This has been loaded. Thank you. Thank you so much. Look, when you opted, I know you're mostly Jewish or you follow Jewish law. And I said, wow, now Saturday, Joel is winning. I am so grateful, because I know your weekdays are tough.
We're doing the Lord's work here. We're trying to keep people alive and healthy and able to attend more family events. I mean, these are, we have had a fun conversation, but these are the critical questions that are not being addressed in standard medicine. And, we never said it, but still number one killer of men and women in the Western world. More than 700,000 people a year in the United States die of coronary vascular disease. This is the worst number I know in the world. 1,000+ people a day die of something called sudden cardiac death. They didn't get to say goodbye. They weren't in hospice. They didn't have their family around them, and it was a beautiful moment. They find them dead on the toilet. Or they find them dead in bed.
A lot of the celebrities and actors who are dying is from that scenario.
Sudden cardiac death should scare people. And that's the reason, go get that heart CT scan, go find a carotid ultrasound, get the extra biomarkers, explore the science of healthy, clean diets of a variety of causes, and stop dying, people.
Yeah.
So sad. We have a death in Detroit this week of a 57-year-old woman married to a prominent media personality. And I mean, just rip your heart out.
Yeah.
I mean, I wish I had seen her a year or two before, or 6 weeks before. I mean, I don't know any of the circumstances of her actual, pathophysiology, but just let's get to these people and stop these tragedies.
I agree. Joel, thank you so much. Last final thoughts, and how can people get in touch with you? And we'll put that in our show notes.
I'm in Motown, Motor City,
Woo.
and I have a very active clinical practice that extends to many states in the United States because of licenses. So I'm at www.drjoelkahn.com, drjoelkahn.com. Take it to my podcast, take it to my clinic, take it to my books, and we have a good time with people.
Joel, thanks so much. I really appreciate it. See you soon, my brother, at probably some conference, or if not sooner. And, have a great day.
Thank you very much. Enjoyed every minute.
Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.